Good evening, judges and my fellow colleagues. I'm going to talk to you today about surgical nightmares. When you have cases like this, you enter the OT with trepidation. You may have a brow which is sort of frowning or probably sweaty, and you have to go and make the best deal of the worst kind of situation which is facing you. So let's look at a few cases. This is a 65-year-old patient who came from Indore. She had multiple surgeries in the past over nearly 10 years at Indore. She was one-eyed. She had glaucoma surgery in one eye, cataract surgery, 3 keratoplasties, and she was surviving with hand movements close to face vision, with which she was managing all her activities. Then she has an injury with a bedpost, and that visibility went down to seeing a shadow since 20 days. She then came over to Bombay, and her USG showed kissing hemorrhagic choroidals in that eye. Now, just look at the gruesome appearance of this eye. A lot of panels, 3 keratoplasties, so you can imagine what was the status. Glaucoma surgeries, there was filtering site, and this was one had to really think out of the box that what and where would we place the incisions for the suprachoroidal drainage. So let's have a look at the So we placed a AC maintainer in that eye, and we went further back to the height of the choroidal, much beyond, and we did our drainage from that site. We had kept a graft ready because that day I did not have a temporary keratoprosthesis because it was stone and I needed to put the graft and then do the surgery. So after I felt that the returning fluid was clear, then we went ahead with the graft, which was sutured in place, did the vitrectomy thereafter. And after creating a lot of mark, there was still a little bit of residual blood. We've done a fluid gas exchange. So reasonably okay. I put a buckle all around so that there was sort of good tamponade because I didn't know whether there was a break in the periphery or not. Now the case number 2 is a history of cataract surgery which was done elsewhere. Patient was on blood thinners, had not stopped that before the surgery. There was suprachoroidal hemorrhage on the table. The clearance was attempted somewhere else after 14 days of surgery, and then she was sent for an opinion after 1 month for treatment of residual bleed with a contracted retina. So this was the patient. A 3-port vitrectomy was done. There were areas of pooled blood which was removed. The retina was highly contracted, and there was blood lying pre-retinal and under the retina, surface of the retina. It was a highly contracted retina with a blood which was congealed in the periphery. There were a lot of membranes under the retina, which was meticulously removed. And one really didn't know how this case would fare, but then we were giving it our best shot. All the membranes were carefully removed. And then we used a brilliant blue dye to stain the ILM, and the ILM was carefully removed. And then a lot of massaging and coaxing the retina happened to allow the retina to become a little compliant with what we were trying to achieve from it. And after a lot of back-breaking work on the retina, where the periphery was then, it was converted into a large retinectomy. We were able to settle the retina, the laser being done for it, and then the PFCL was removed towards a good conclusion of a horrible case. Now, this was a 74-year-old lady who had history of brittle diabetes, hypertension, cholesterol issues, hypothyroid. Stenting was done in the past. She was on 13 oral medications, inclusive of blood thinners. She had cataract surgery for a hard cataract, had a nucleus drop, which was removed with vitrectomy PFCL through lumbus, as it was resistant to sonification, with a resultant suprachoroidal hemorrhage on the table, which was dealt later after 18 days with vitrectomy and a suprachoroidal hemorrhage drainage. This is a very hard cataract, and on sculpting, this had descended into the eye. The surgeon had done a vitrectomy with a removal through the limbus, and then it was repositioned, and at the end of surgery, after the sutures were taken, the suprachoroidal hemorrhage ensued, which was the cause for it being a nightmare case. And then later, this was drained, and it was kind of dealt with. But
Karobi, 1 minute.
yeah, but the ultrasound on the right shows, just a moment more, it shows an attached retina, but if you see 3 months later, the patient redetached, and she had to take some time because she was not well, and she went in for surgery again at a prime institute after 5 months, but she bled again on the table on the completion of successful detachment surgery. So this case was doomed to failure. I'll just show one more case, can I?
Running X.
Okay. This was another case where we have done a TKP. Finish, okay. This will almost get over now. A TKP was done and a vitrectomy was done through it. The conclusion was good of this patient. Thank you so much for your kind attention.
Yeah,